So as sir mentioned, the classification this time has specific importance because a lot of the contribution came from our country, and I think the significant contribution has been the understanding of this aggressive, what used to be called aggressive posterior but now called aggressive ROP. And I'll just move to the pictures. So the images show what kind of aggressive ROP we see. And the fact that posterior was dropped was because all the way anteriorly you can see these capillary non-perfusions, which sometimes get misdiagnosed or underdiagnosed as just avascular retina. So these are the subtypes, and in fact these parts of the publication have come from Indian images. The other thing is regression and reactivation. Reactivation Dr. Simar touched upon. So I'll just talk about regression. Now regression and reactivation are two new terms that have been added to the new classification. And reactivation most particularly seen after anti-VEGF therapy, and as he mentioned, that can vary from what drug you use and what dose, and of course what the age and the gestational age or the postmenstrual age of the child is. What's important to understand here is that reactivation can be either the ridge reactivation or just plain vascular reactivation. So you don't have to wait for stage 1, 2 and 3 to develop again to decide to treat. Even if you start seeing a stage 1 or a 2, often it requires treatment because it has got reactivated after injection. Imaging devices have seen a lot of new thrusts from our country. So this is of course no longer new. It's about now 6 years old. They have an FDA CE approval. It has more than I think 100 country installations. That's the Neo. But what's new about the Neo is now they have the angio unit, which I think is very good because as we give more and more anti-VEGFs, angiography is going to play a very important role in following up these babies and deciding when to treat the reactivation. The MII RedCam is another Indian innovation. This is actually a 20D attached to a sort of phone, mobile phone kind of attachment. And similarly, the group in Ahmedabad, they also have a slightly more pliable model where you can look at the periphery, and this is handheld, and they've tried it with the healthcare workers as well. Imaging techniques, of course, we know angiography is not new, but its use in post-anti-VEGF cases is new. Now, in this case, please look at the image on the top left, and that's a very innocuous looking retina that's been injected and lasered somewhere else almost a year back, and it looks as though it's an inactive disease, but look at the angiogram below and shows you still such an active disease, and it still requires treatment. OCT is another newer imaging modality because it's a handheld device, and we are understanding now that there is macular edema in these infants which does not require treatment but needs follow-up, because some of these children who have this edema end up having lower vision as early as 6 months to 12 months, and they have to be corrected with vision stimulation. OCT angiography, if you hold the baby in a flying baby position, we are able to look at, not even though they are 6'9" or better, so they are normal visually, they're normal ophthalmoscopically, but their foveal avascular zones are not normal, and their superficial capillary plexus are not normal. We've also now been able to check the contrast of babies as early as newborn babies, or at least 1 month to 3 months. And what's important is impaired contrast also can predict their vision 3 to 6 months later, and this was one of our PG theses. Predicting ROP is very exciting. Imagine now we are able to take the tears of these babies, and let's hope the video plays. Yeah, we are able to take tears of these babies during their first screening and take it to our lab, and 20 millimeters on the regular Whatman filter paper, and we look at some of these biomarkers which are seen in the tears, and from there, and we've just published the initial work, we're able to predict which of these babies will get the disease. We are soon going to be able to follow up and tell you which of them will require treatment requiring disease. So this is very useful because right in the first screening itself, you can triage these babies saying, okay, you're more at risk, you're less at risk, and maybe your follow-up pattern will change accordingly. After the 2015 landmark judgment, which the Supreme Court laid more than 1.6 crores against, for a missing ROP and the child turning blind, we've reported some of these law judgments that out of 7 so far, 6 have gone against the pediatrician and 1 has gone against the pediatrician and the ophthalmologist. So understanding what we have learned from these cases, we've sort of summarized that into a publication, but I think understanding the fact that we must follow the current guidelines, require the consent the way it has to be taken, document it, and make sure they are followed up on time. So an error of treatment, an error of judgment is not wrong, but not following them up on time, or just saying 3 weeks, 4 weeks without calling them back, or not understanding if they are transferred from one NICU to the other, making sure that the continuity of care happens to someone else, all these can amount to negligence. In the pandemic, the Indian ROP Society was the first actually in the world to come up with guidelines on how to modify screening guidelines during the pandemic, and this was followed by all the SAARC countries. We are happy to say that our country, although did see some advanced cases because of the pandemic, but most of them were prevented on time because we were able to continue screening despite that. I'm going to end with artificial intelligence and machine learning. India is making some good strides. There are groups in Pune, we've been doing some work, and in Delhi and Chandigarh as well, where we're taking these images, segmenting the vasculature, and then putting it into an AI algorithm. I just want to tell you our latest algorithm, which is now getting integrated in telemedicine platforms, is able to predict which baby, or just from an image, the system is able to tell you whether it's stage 2 or stage 3. And if this goes into the real world, you can imagine as thousands of images come out from low-cost cameras, AI will be able to do the initial triad so that only those babies who require treatment will require to be seen by the specialist. So we are at about early 90s sensitivity, which is good but not awesome, but that's work in progress. Thank you very much for the patient hearing.
Anand, I think excellent as usual. The one thing you mentioned about that 1.6 crore, I know the case.
Sir.
Was the case, was that compensation paid to the patient?
Sir, the government of Tamil Nadu paid for it because it was a government hospital.
Okay.
The two neonatologists were actually retired, and they were they were professor emeritus.
Right, I know.
They were called back, but government took on the responsibility to pay it because of government hospital.
I know.
So any other question? Time is not on our side, but one question I had was, I am aware of the tear film biomarkers which ANAND is doing. One patient you showed where, clinically it was looking okay, but angiography showed. So the question comes, how frequently the angio is recommended?
So as Simar mentioned, and we're trying to make this part of the IROC guidelines, if you are convinced that you are going to do the laser after anti-VEGF under topical anesthesia, then the surgeon's comfort would be around 4.5 to 5 kgs. After that, it's a little hard. And that usually happens between 48 and 52 weeks of post-menstrual age. So that's when we do the angiogram, document how much of persistent avascular retina there is, and then do the laser. But like in the West, if you are convinced that you can do it under GA, let's say you're a teaching hospital or you have that facility, you can go up to 55 or 60. Because after that, what happens is peripheral retinal avascular or incomplete vascularization starts telling on foveal development. So if you've not vascularized the periphery by at least 50, 55, then you will have a structural and functional disadvantage as the baby grows up. So that's roughly the line we have to draw between 48 weeks and 60 weeks.
Okay, thanks Anand. Lots of learning from this